Test 1 2 1 2. Testing 1 2. Test 1 2 3 1 2.
Even when I'm in a Google with Mike, and we haven't done that often, I still say, oh, let's text that and tell them what we're doing. You know,
I can stay right here? Yeah, it's fine. Gonna eat? Sure.
Have you got your overhead? Yeah.
Yeah. You ready? Oh, I can't do that. I got a sore throat. We have to turn it up. It's not loud enough. You be okay?
Yeah.
Okay. Let me just go ahead and get started. All right, so I guess we'll go ahead and get started. So, my name is Trent Howard. I'm a cardiothoracic and vascular surgeon here at St. Vincent East. I've been asked to talk today about how, as a thoracic surgeon, we approach lung cancer. I try not to get too far into the weeds of some of the things I'll talk about, but if you think that I'm getting off track, just ask a question. I'll try to get back. I don't have anything to disclose other than the fact that I hate lung cancer. Took my father way too young, and so that's one of the reasons I chose to be a cardiothoracic surgeon is to fight lung cancer every day as much as I can. So really, just the purpose of today is just to understand the presentation, the workup, and the preparation for lung cancer surgery and what it takes to get somebody into my operating room. The operative options for lung cancer surgery, the things that I can do as a surgeon to treat the disease. And we'll talk some about lung cancer staging and treatment. I do have some slides on different stages and just kind of some general treatment guidelines, but the NCCN guidelines are really kind of user-friendly. They look kind of intimidating the first time you look at them, but if you really follow the chart, it's really user-friendly, so very helpful. So a little bit of background on lung cancer. We all know it's the second most common cancer among men and women. Most common cancer among men is prostate, and women is breast cancer, but it's the leading cause of cancer death among both sexes. Last year, 220,000 new lung cancer diagnoses and 142,000 lung cancer deaths. The all-comer 5-year survival is 18%. That's everybody. That's people with early-stage lung cancer, it's people with metastatic small cell lung cancer, everybody thrown in the pot. 5-year survival is only 18%, which is pretty miserable. 85 to 90% of them are caused by smoking. We do know there's about a 20-year latency period between the peak of somebody's smoking history and the onset of cancer. And so we thought, in the mid-90s, that was kind of the peak of the smoking time in America, and so now things should be kind of slowing down, and they're really not. So there may be some other causes out there that we haven't really figured out yet. However, the National Lung Cancer Screening Trial, which was published a few years ago, where we started doing low-dose CT scanning of people at high risk for lung cancer, has reduced the risk of death by about 20% because we're catching these cancers earlier. It's not because we're not getting cancer, but because we're catching them earlier and they're not as advanced and we're able to treat them more effectively. Generally, there's 3 types of lung cancer. We can get into a lot of different histologic types, but generally adenocarcinoma, squamous cell carcinoma, and small cell carcinoma are the 3 general types of lung cancer. So how do we find these? I already talked about the low-dose CT scanning of people that were at high risk, and their primary care doctor, the pulmonologist, got this CT scan where they found this lung nodule that was worked up. Other imaging, so grandma slips and falls, breaks her hip, has some belly pain, she gets a CAT scan that gets the lower part of her chest, and they see this right lower lobe lung nodule. Just incidental finding. That happens a lot. Actually, after trauma or people come to the ER with trouble breathing or whatever, they get a chest x-ray and a CAT scan, and then they kind of start down this path of the workup of this lung nodule. Symptoms. I said my dad died of lung cancer, and he was one of these guys, just an old tobacco farmer, never went to a doctor, and he got a cold in one fall. It wouldn't go away. And finally went to a doctor. He had a cough, he had chest pain, chest soreness, got a chest x-ray, and he has a big lung mass. And so people still present that way, especially in the South. You get these guys that just refuse to go to the doctor. They're old farmers or factory workers or whatever they are. And then finally they can't get over something, and the wife's pushing or the kid's pushing. They finally go to the doctor and they get this imaging, and things are found. So talking about lung nodules, a couple different types. There's a solid type lung nodule and non-solid. And the non-solid, without getting too detailed, you have ground glass opacities and partial solid lesions. Oftentimes these part solid lesions are adenocarcinoma in situ, or very early lung cancers, and if they're caught early, diagnosed early and resected, there's 100% 5-year survival. And these are the people that we're really picking up on the low-dose CT scannings. The solid and part solid are more likely to be neoplastic, and they're followed and treated more aggressively than just the ground glass opacities. So there's a low-risk group and high-risk group. Obviously, you can think, the high-risk group are people with a long smoking history or a lot of exposures or previous other types of cancers. So lower-risk nodules, if they're less than 6 millimeters, the NCCN actually doesn't recommend any follow-up at all. 6 to 8 millimeters, you get a repeat CAT scan in 6 to 12 months. If they're greater than 8 millimeters, then you have kind of an option to follow it. With a repeat CAT scan in 3 months, you can get a PET scan, or you can just send them on for biopsy. The high risk is a little closer follow-up. That should be less than 6 millimeters. Just another CAT scan in 12 months. So you get a 65-year-old guy, been smoking for 40 years, has this 5 millimeter nodule on a low-dose CT scan. You just repeat it in a year to see if it's changing or getting bigger. 6 to 8 millimeters, they get a CT in 6 to 12 months. And again, greater than 8 millimeters, you have some options to pursue this. The subsolid nodules, the ones that are pure ground glass, like I said, they're a little less aggressive with these. Greater than 6 millimeters, you still repeat it in 6 to 12 months just to make sure you're not missing anything. The part solid ones are followed a little closer, and if you have multiple nodules, obviously another reason to follow these things a little closer. So, diagnostic evaluation, and this is directly from the NCCN guidelines. The patients with a strong suspicion of stage 1 or stage 2 cancer, they don't necessarily require a biopsy prior to coming to see the surgeon. It does add time, it adds cost. There's a risk with every procedure, whether it's a bronchoscopy or a mediastinoscopy or transthoracic biopsy, whatever it is, there's always procedural risk with anything that we do. And especially if the nodule's in a place that's difficult to get to. A lot of times we see people in my clinic with a nodule very deep into the lung parenchyma. It's not amenable to bronchoscopic biopsy, not amenable to transthoracic biopsy, oftentimes not amenable to even a wedge biopsy on my part. And we have done some lobectomies for a diagnosis, just because the mass of the nodule is not in a location that's easy to get to. We have some different diagnostic tools. We talked about bronchoscopy already with biopsy. We can use sputum cytology. It's very, very non-specific, but it can be done, especially if there's an endobronchial lesion. Image guided. The interventional radiologists do a great job of needling some of these peripheral lesions, especially. Thoracentesis to rule out, essentially stage 4 disease, but if there's an diffusion associated with lung cancer, a thoracentesis can help. Mediastinoscopy, which is something that we do, as well as the surgical biopsy. Other things that are out there that are available are the EBUS, the endobronchial ultrasound, so bronchoscopy within ultrasonic guidance to the lesion, where you do a needle biopsy. EUS is through the esophagus, and navigational bronchoscopy. I don't have a video of this, but I wish I did. It's kind of cool. You upload the CAT scan to the navigational bronchoscopy, and it kind of gives you a roadmap, like you're driving down the road, to get to this lesion and where the lesion actually is, and allows you to biopsy it. So we're working on getting that here, but there are some other places that do have that available to them. Bronchoscopy in general should be performed before any kind of surgical resection. It doesn't necessarily need to be done preoperatively. They don't need to come to my office after having a bronchoscopy. But if I'm doing surgical planning, or if I think there may be some endobronchial portion of this mass, or it may be necessary for me to do a little more advanced resection for this, then that's something that I would do intraoperatively. So bronchoscopy is almost always done before any kind of surgical resection, whether it's me or the pulmonologist or somebody else. Mediastinal staging. Again, the guidelines suggest that before any kind of surgical resection, the mediastinum should be staged one way or another. Not necessarily, shouldn't be done as a separate procedure, although there are people out there that will do the mediastinoscopy, bring it back another day and do the surgical resection. I think it's, for me, it's kind of a waste of their time and my time, and we need to get it done in one day and figure out what it is and take care of it. PET scans often are done before the diagnostic biopsy is done, and most people that come to my clinic have a PET scan done. They have a hot nodule, they have something that showed up in the mediastinum, and they wind up coming to me for surgical biopsy or surgical resection. The two most important things to me, well, really the one most important thing to me is PFTs, because I'll do a frailty assessment in my office. There are a lot of different frailty assessments out there, whether it's a Carlson comorbidity score or whatever kind of score you want to use. But the thing that's probably more accurate than anything is just the eye test. Oftentimes you can walk into somebody's hospital room, you can walk into the exam room, and you can see them sitting there and know if they're going to tolerate a lung resection very well or not, especially after some experience. PFTs are real necessary before any kind of lung resection, just to tell me if they're going to be able to tolerate it. If their PFTs are not amenable to a lobectomy, even though the guidelines don't necessarily recommend it yet, you can do a sublobectomy or a segmentectomy or a wedge resection, or if they're just not a candidate for any kind of surgery at all, then you send them to a radiation oncologist. So the PFTs are probably the most important thing that if I don't already have them in my hand when I see them in my office, that I'll get done. Then a multidisciplinary evaluation. All the NCCN cancer guidelines recommend multidisciplinary evaluation for any kind of cancer now, and lung cancer especially. And you're talking about the surgeon and the pulmonologist, the medical oncologist, the radiation oncologist, the radiologist, everybody kind of sitting down together and talking about especially some of the more complex cases and deciding what's the best approach to take, and if there's any more diagnostic workup that needs to be done, and what kind of treatment they need. So why would I do a mediastinoscopy on somebody? If somebody comes with a PET scan that has a mediastinal node that showed up on the PET Avid, someone with a known cancer and a mediastinal node that's greater than 1 centimeter, it's an indication to do a mediastinoscopy first, and we'll talk about why here in just a second. or if there's just a strong suspicion of mediastinal nodal involvement based on the CAT scan or the symptoms or having chest pain or whatever. If I think there may be some mediastinal nodal involvement, that would be an indication to do a pre-op mediastinoscopy. Any tumor size greater than 2 centimeters is recommended to do a mediastinal lymph node biopsy. And these are all recommended by the NCCN guidelines. So what usually happens? We talked about already there's some imaging involved, whether it's screening imaging, whether they came to the ER with chest pain, with their primary care doctor with shortness of breath, whatever it is, there's almost always some imaging. There may or may not be a biopsy if it's reasonable and necessary. People that come to my office for surgical resection don't necessarily have a diagnosis of lung cancer, and oftentimes they don't. Oftentimes it's just a suspicion of lung cancer. And PFTs and frailty assessment. So once I have all these things kind of in my hand and in my head, then I can decide the approach for tissue diagnosis, whether or not to do any kind of mediastinal staging, the resectability, or how I'm going to take care of this patient, or if I need to send them to see somebody else. Questions about where we've gotten through so far? Going through this kind of quick. All right, so I'll try not, like I said, I try not to get in the weeds too much with the staging, because the NCCN guidelines are free and available to anybody online, and they're pretty user-friendly. But the 8th edition of the guidelines came out, 2 years ago now, I guess. The most updated version of the guidelines, where they changed the staging some. So stage 1A1 is a tumor less than 1 centimeter, whether this is pre or post surgical diagnosis. Anything less than 1 centimeter, if it's diagnosed as a cancer, then it's stage 1A1. This is surgical resection with mediastinal node dissection or sampling, if they're a surgical candidate. If they're not a surgical candidate, and we're talking about people that are 85 years old and on home oxygen and not ambulatory, not going to tolerate any kind of surgical resection, then these people can be referred for radiation therapy, which is usually the best option for those kind of people. 1A2, that's a tumor from 1 to 2 centimeters. Again, exact same treatment as the 1A1. 1A3, this is a 2 to 3 centimeter lung cancer, where you're getting a little more risky, but still it's a surgical resection, mediastinal lymph node dissection or biopsy. And if not a surgical candidate, then they go to radiation therapy. Stage 1B, where you get a tumor that's 3 to 4 centimeters. Again, surgical resection, these people are still resectable with mediastinal nodal biopsy or dissection. And then you consider chemo for any high-risk lesions, high-risk patient or high-risk lesion. And these are lesions that are more aggressive pathologically. Again, if not surgical candidate, radiation, and maybe even adjuvant chemotherapy as well. Stage 2A, this is a tumor of 4 to 5 centimeters. Once you reach tumor size greater than 4 centimeters, then part of the preoperative workup is a brain MRI. Most of the CAT scans and PET scans go through the adrenals. Those are the two most common places for metastatic lesions to show up, is in the brain and in the adrenal glands. But if you don't get a brain MRI preoperatively, you really haven't worked up these people appropriately if they have a lesion greater than 4 centimeters. Still go to surgery, still sample the mediastinal lymph nodes, chemo for high risk, and if there's any positive margins at all, they get chemo plus or minus radiation therapy. And these positive margins can be on the bronchus, they can be in the peribronchial tissues, they can be the chest wall. We'll talk about a little chest wall invasion a little bit, but if there's any kind of positive margin at all, these people are often referred for radiation therapy. Again, if they're not a surgical candidate, they still get radiation therapy and maybe even chemo. So T2 in general, 3 to 5 centimeters in size is T2A and T2B. It can involve the main bronchus without the carina, so where the right and left mainstem bronchus divide. As long as it's not involving the carina, it still could be a T2 lesion. This could be a 1 centimeter lesion involving the left main bronchus. That's a T2 lesion. If it invades the visceral pleura, so the pleura on the outside surface of the lung, if there's any evidence of tumor tissue there, whether it's a 1 centimeter or less than 1 centimeter, it's still T2. Or if it causes atelectasis or any kind of obstructive pneumonia. Stage 2B, these are the T3 tumors, 5 to 7 centimeters, with any invasion of the parietal pleura, the chest wall, not including superior sulcus tumor, which is a whole separate thing that we'll talk about. The parietal pericardium, the phrenic nerve, or a separate nodule in the same lobe. So 2 separate lung cancers in the same lobe, no matter the size, it's still a T3 lesion in stage 2B. 2B is also, I can't, does this show up when I do that? Not really. Is there a pointer here? I can't see it real well. Anyway, T2B, you see we've been N0 so far, and we'll talk about the nodes as well, but this is an N1 lesion. So these are hilar lymph nodes or intralobar lymph nodes that have cancer disease inside of them. So now we're talking about lymph node involvement. These people, besides resection and the mediastinal nodal dissection that we always talk about, these people are referred on for chemo and oftentimes radiation if there's positive margins or close margins or if it's higher risk. So T3, these are the 5 to 7 centimeter lesions, or any lesion that directly involves the parietal pleura, the chest wall, including the superior sulcus, and this is thoracic outlet structures, the phrenic nerve, parietal pericardium, or a separate tumor nodule in the same lobe that we talked about before. So this is actually an intra-op photo that we did a chest wall resection. Took out, if I remember correctly, ribs 4 and 5. Depending on where you have to do the resection of the chest wall, it has to be reconstructed. And this is mesh reconstruction. You can put plates and muscle flaps and all kinds of things to reconstruct the chest wall. But this is a nice tight mesh that's tight like a drum, so you kind of maintain that integrity of the chest wall. So any kind of chest wall invasion that requires a resection, especially in certain areas of the chest, has to be reconstructed. You can imagine, you can see the tip of the scapula. You can't really see it, but the tip of the scapula is right there. So if I don't reconstruct that, every time they move their arm back, the scapula drops down into the chest. So that's the reason that oftentimes the chest wall has to be reconstructed. Just another picture from a different angle there. So nodal staging. So you have stations 1 through stations 14. Double-digit nodes down here. These are the hilar nodes and the intralobar nodes. These are N1 nodes. So if you show up in the hilum or something in intralobar with a positive node on pathology, that's an N1 positive node. The mediastinal nodes are the single-digit nodes. And the ones we often see are level 4, which is along the trachea, level 7, which is subcoronal, 5 and 6 around the aorta and the pulmonary artery on the left side. Oftentimes in the mediastinoscopy, we'll get kind of high up on the trachea and get a level 2 node as well. But those are most of the nodes that we see. And just know that mediastinal nodes are single digits. Those are N2 nodes. Hilar nodes and intralobar nodes are double digit, and those are N1 nodes. We also talk about N3, that's not really resectable, but N3 nodes would be a node on the opposite side of the chest. So you have a right upper lobe mass with a hilar node in the left hilum. That's an N3 node, and those are not resectable. T4, this is a tumor greater than 7 centimeters. Also any size tumor that invades the diaphragm, the mediastinum, the heart, the great vessels, the trachea, recurrent laryngeal nerve, esophagus, vertebral body, or a separate tumor nodule on the same side lobe. So a right upper and a right lower lobe mass that are both cancers. That's a T4 cancer regardless of the size. And T4 lesions, some of them are resectable, as you can imagine, and if you look at what they invade, some of them are not resectable. So it really depends on what they're invading. So stage 3A cancer is where some of the really more important multidisciplinary evaluation comes in, because some of these patients are resectable and some of them are not. Technically, 3A disease is resectable, depending on the patient and the location and what's involved. Sometimes they need neoadjuvant chemo and radiation, which is pre-surgery chemo and radiation. Sometimes they need adjuvant chemo and radiation. So this is where the multidisciplinary evaluation really becomes important. So these are people with small tumors with mediastinal nodal invasion. And we'll talk about some of the controversies with mediastinal nodes and these smaller tumors, but also bigger tumors with hilar node invasion can be classified as stage 3A disease. I mentioned superior sulcus tumors a few minutes ago. These tumors are at least a 3A. They always involve the chest wall and the structures of the thoracic outlet. These are big tumors, way up high, very symptomatic, very painful, and it's a big resection. And two of the most important treatments for this, number one is to rule out mediastinal disease. If they have mediastinal lymph nodes with this much of invasion, it's not resectable. They're a chemo radiation candidate. But they always get neoadjuvant chemo radiation to see how the tumor responds, to hopefully shrink the tumor, to decrease the amount of resection you have to do, and plan your surgery from there. These are big big resections and big incisions, and it's a big deal for these patients. Again, we'll talk about treatment. Some 3A disease needs neoadjuvant treatment, just like the superior sulcus tumors. Some 3A disease is not resectable based on what it invades and the status of the patient. But most all require some kind of chemo or radiation either before or after surgery. So some of the controversies of 3A disease, especially talking about N2 disease. So these are 3A lesions with mediastinal lymph node involvement. Surgery has not consistently shown to increase survival in these patients because it's already aggressively invaded the lymph nodes. And so recurrence is pretty high, and the 5-year survivability is very high. Neoadjuvant versus adjuvant chemo really depends on the tumor and sometimes on who's doing the treatment. The timing of radiation, and if it's necessary, is still not known for some of these lesions. Whether they should get it before or after or at all, and how much they should get. A lot of that is still not known for sure. And surgery may be appropriate to those that respond to induction therapy. So some of these really large, aggressive cancers respond very well to chemotherapy, and they, even though they may, by guideline, not be resectable, a lot of times they find themselves back in my office to talk about, can we do surgery on them or not? And sometimes we do, and sometimes we don't. Stage 3B, these are technically not resectable. Now we did have a lady recently that the pathologic staging was 3B. We didn't know she had a mediastinal positive node until after the final pathology was back, but we did the resection and she actually did very well. But technically these are not resectable lung cancers. Questions about the staging, like again, I said before, the NCCN guidelines are, even though they look kind of intimidating when you look at them, they're very straightforward and easy to follow and free to anybody that wants them, so they're not hard to find. So operative approaches, so really there's about 3 different options for me to offer somebody when they come into my office. Traditionally, the thoracotomy was what most people got, especially with older surgeons. Before the technology that we have available to us now is available to us, it was really the only way. The only way into the chest was through the ribs. It's a painful incision, it's a painful operation, it's a painful recovery. Sometimes it's necessary, even today, even given the technology you have available to us, it's still necessary sometimes. But you can see that's a big incision between the ribs, dividing the muscles you use every time you breathe, the muscles you use every time you twist, every time you move, every time you try to get out of bed. So the recovery is quite painful. This thoracotomy that I actually did recently, not for lung cancer, but again, you can see I've cut a piece of rib away so we can spread. Gone through the muscles. I'm pushing other muscles out of the way. I'm stretching things out. It's a painful incision and a painful recovery, especially when you get these. I won't say little old ladies because they're tough, but little old men that don't want to move and don't want to breathe and don't want to cough. This is a tough recovery for them. Again, another thoracotomy that we did recently for another reason, but again, you see the size of the incision, kind of right below the scapula. That's just a painful place to put an incision. Again, sometimes it's necessary, but the recovery for these patients is a lot more intense. Video-assisted thoracic surgery, or VATS surgery, has been around for, I don't know, maybe 20 years or so. You see a couple of different ways, and everybody has their own way they're trained to do, 2 ports, 3 ports, 4 ports. This is the way I do it, with 2 ports down low and an access incision in the axilla. A lot less invasive, a lot smaller incisions than thoracotomy, but still not without its own pain associated, especially with that access incision and those port sites where you're kind of cranking down on the ribs with the camera and the instruments. A lot better than the thoracotomy, but still not great. Chest surgery in general hurts. I mean, you can imagine everything we do to your chest, every time you breathe, every time you move, you feel it. So part of the workup for these patients, like I said before, is the frailty assessment and the eye test. Are they going to be able to tolerate what I have to do to them? I have a video that I'll show at the end of that surgery to kind of document that. There's a view just kind of looking inside. That's a camera looking inside the chest. Lungs not completely deflated at this point, but you kind of see the view we get from down below with the camera looking up toward the top of the chest. And that's the video we'll show here in just a second. Robotic, and let me preface this. When I trained as a general surgeon, robotic surgery was fairly new. We kind of made fun of it a little bit because, you know, we do laparoscopic choles and laparoscopic colons. They're pretty straightforward and easy to do, and we thought, well, why would you take a perfectly good operation and add some more time to it to do the robot? So we kind of made fun of it a little bit, but, you know, we were trained to do it. Same thing when I did thoracic surgery. We thought, you know, we have VATS, you know, lobectomies that we're pretty good at doing, and we can do them pretty quickly. Why would we take that and make it more complicated or add steps to it? But the bottom line is you don't add steps to it, and it's not more complicated. It's actually very good. And what I tell patients in my office now when we talk about the surgical approach is that thoracotomy is always the emergency backup. Something happens, I make something bleed, we get some unexpected intraop finding that I can't do minimally invasively, then thoracotomy is always the backup. So we always talk about the thoracotomy incision and the recovery from that. When we talk about VATS versus robotic, VATS is like playing a video game. I have instruments on the outside, I'm watching on the screen what I'm doing. Now I'm also old enough that I was raised on Atari and Nintendo. My children were raised on this high-def 3D, and if I try to play video games with my sons now, they literally run circles around me, and I don't even know where they're at. So I'm not great with video games, but I was trained to do VATS, so I'm not bad with VATS lobectomy. But the difference between VATS is me playing a video game versus robotic, where it's like, and I actually tell the patients this, my head and my hands are inside your chest. I'm looking exactly at what I'm operating on. I'm looking at the screen, I'm right there. And I'm really amazed, I have to confess, I'm amazed at the difference in the visualization and the technology between VATS and robotic. And you know, we've been doing it here for a little while now, and we're having good success. We're actually seeing patients upstaged because we can see the nodes better, we can see the anatomy better, we can harvest more lymph nodes, so we get a better pathologic staging on these lung cancer patients with the robot compared to thoracotomy or VATS. And I really have to publicly say that I should never have made fun of the robot because it's actually a great tool for me. So this is that's kind of the standard robot setup. Yes, there's 4 to 5 ports. They're also 1 centimeter incisions. One of them gets a little bit bigger because you have to take your specimen out in a bag. But these people, I mean, the next day they're sitting in the chair and they're not on oxygen, and so yeah, I'm a little sore. It's not so bad, and they're walking around and they're able to urinate. A lot of them will go home on post-op day 2 because they don't have an air leak and the pain's not too bad, and they're able to get the chest tube out sooner. So just a world of difference, light years difference in the technology and the way we're able to take care of patients between VATS and robotic. So like I said, the advantages of the robotic approach is a lot less pain. Even though there's more incisions technically, there's smaller incisions, and the robot actually, instead of cranking down on the rib with the camera or the instruments, the robot actually has a point on the fulcrum at the rib. So the instruments move around without pushing on the rib, without putting pressure on the neurovascular bundle under the rib. So the pain post-operatively is a lot less. Shorter length of stay, less of an air leak, and like I said, improved lymph node dissection. We're already seeing patients that are having their cancers upstaged because they're getting more lymph nodes from more stations and doing a better job with our resection. Questions about surgery, which is kind of why we're here. All right, so talk a little bit about the research, why we do what we do. So why is a lobectomy the proper operation for lung cancer? This is starting to come into question a little bit, but the reason we still do lobectomies is because in 1995, there was actually a very well-designed study comparing early stage lung cancer, doing limited resection, which is basically a segmentectomy or wedge resection with a 2 centimeter margin versus a lobectomy. And what they found is that there was a 3 times higher recurrence rate in someone who did not get a lobectomy. So the recurrence rate was 1/3 if they got a lobectomy versus having less than a lobectomy. That was in 1995. It's been proven again with other follow-up studies. There's also some research out there talking about sublobectomies or segmentectomies that's calling this into question a little bit. So who knows what we're going to be doing in 5 years, but there are a lot of people out there advocating that you may not necessarily have to do a lobectomy on every patient, especially in the early stage cancer and the people that we're seeing more often that we're catching them in earlier stage. Mediastinal lymph node dissection versus sampling. this has kind of gone back and forth with the research as well. The Z70 trial, which is published in 10 years ago, maybe, I don't remember exactly when it was. Again, a well-designed, randomized control trial. And they found that people with early stage disease with these small lesions, if you did a mediastinal lymph node dissection, they had no increase in survival. So what am I talking about, lymph node dissection versus sampling? When you look at these mediastinal lymph node stations, do you take out all the nodes? That's a dissection, or all the nodes you can find, all the nodes you can see. Sampling is just, do you grab a node from that spot or not, randomly? So that's the difference between the mediastinal lymph node dissection versus mediastinal lymph node biopsy. People with advanced stage diseases, however, the 3A, the mediastinal lymph node dissection, they recommend it should be performed because, again, these are larger tumors, they're more advanced, and oftentimes they're more aggressive. So it's more important to get the entire lymph node packet versus just sampling to see if there's anything there. Right-sided cancers, we should be getting nodes from stations 2, 4, 7, 8, and 9. Left-sided cancers, 4, 5, 6, 7, and 9. That's just the anatomy of the right and left chest. NCCN guidelines recommended sampling at least 3 mediastinal lymph node stations, especially in these early stage cancers. And again, like I said, newer research and practice leaning toward mediastinal lymph node dissection on all. And in our hands and in mine and my partner's hands, we've seen some patients upstaged by doing more aggressive mediastinal lymph node harvest. So segmentectomy versus lobectomy for early stage cancer. This is a little more recent data, 2017, fairly well-designed study where they showed that the survival in the segmentectomy group was not inferior to patients treated with lobectomy. But they do suggest that more evidence is needed because we've been doing this for 20, 25 years. And the research has kind of been all over the place, but this is a pretty well-designed study that showed that some patients in early stage disease may have just as good outcome with a segmentectomy than a lobectomy. And actually in the guidelines now they suggest that segmentectomy may be appropriate for some people. People not eligible for lobectomy, for anatomic reasons, for PFT reasons, if we don't think they can tolerate losing a lobe, then a segment may be acceptable for them. A peripheral small nodule may be treated as well with a segmentectomy, or if you can achieve a clear margin greater than 2 centimeters or bigger than the size of the nodule. So a 1 centimeter mass, if you can get 1 centimeter margins, 360 degrees, that may be appropriate for some people. So the data may be swinging the other way. More importantly, not just for me as a surgeon, but for everybody that is involved in lung cancer treatment and taking care of these patients, is how do we build a good, comprehensive lung cancer program? I'll be honest, what I've seen so far, and I've been here a little less than 2 years, is that it's kind of, I won't say piecemeal, but there's no coordinator, so to speak. We get patients referred to us from primary care doctors, from pulmonologists. Oftentimes primary care doctors send them to a pulmonologist, or an ER will refer them to a pulmonologist to start some kind of the workup. And that's okay, but we need really a more comprehensive program in place to catch these people. I mean, let's be honest, we live in Alabama. There's a lot of lung cancer out there that's not being caught, not being treated, or not being caught early enough, and it's not treatable by the time it is found. So we need a lot of education for the primary care doctors and for the patients, for these people that are eligible for screening, the high-risk screening. Again, I put in quotes a task force. It doesn't necessarily, it's kind of a buzzword, I guess, but just some structure in place to evaluate and refer to the appropriate specialist. If you find something that looks like it's advanced stage, they don't need to come see me. They need to go to a pulmonologist and an oncologist. So somebody just kind of refer people to the right people, and then follow up on the progress to see if they go or not, and see if they show up and see what the evaluation is. The multidisciplinary coordination and cooperation, we actually do that here, and a lot of places they do. We have a lung cancer meeting once a month with the surgeons and the pulmonologists and radiologists, oncologists, and everybody kind of sits down around a table and we discuss cases. So that's kind of going on now. But it would be nice to do that more preoperatively with some of these people as well. Then make sure we have the available resources necessary for the proper workup and treatment, and if not, send them to the place where they have the available resources. If you're a primary care doctor at an outlying hospital and you don't have a thoracic surgeon, you don't have medical oncology, then you need to know where to send these people to get them treated appropriately. So that being said, who qualifies for lung cancer screening? These are separate NCCN guidelines that are also available online, easy to find. But high-risk individuals, if you're over 55, you have a greater than 30 pack-year smoking history, and you've quit less than 15 years, you get a low-dose CT scanner. Greater than 50, the 20 pack-year history, and one additional risk factor that's not secondhand smoke, radon exposure. I came here from Iowa, which is kind of like the hotbed of radon. You know, everybody has radon exposure in Iowa. You can't sell a house in Iowa without having an updated radon testing done. A cancer history, a family history of lung cancer, or people with COPD or pulmonary fibrosis. Those are also the high-risk individuals that qualify, and the insurances should pay for a low-dose scanning CT. And based on findings, annual screenings if nothing is found, or until the patient is no longer a candidate for treatment. So if you qualify at 55, you should be able to get a CT of the chest every year until you reach a point in your life where you would say, I don't want treatment, or I'm not capable of undergoing any treatment if you find anything. So this is why I'm here, actually. That's my dad, probably mid-1980s, but you know, so I told you lung cancer took my dad way too early. I really enjoy heart surgery and vascular surgery, but this is why I chose to be a cardiothoracic surgeon. So, questions? Let's see here.